So a very, very good afternoon to all those who have joined this webinar. In spite of all of our load shedding woes, just to note that this session is being recorded. A special welcome to our esteemed panel of speakers. And on behalf of Lions District 410E and Diabetes SA, I would like to express our sincere and heartfelt gratitude to each of you for taking the time to share your knowledge and experience with us today. November is Diabetes Awareness Month, and this webinar is a joint venture between Lions Clubs of District 410E, on which I, Lion Niroshni Singh, serve as District Chair for Health, and Diabetes SA through the hard-working efforts of my esteemed co-host, Pranisha Deonarai. Facilitating this webinar is our very own tech expert, Lion Kim van Wyk. Thank you so very much, Kim. Shocking statistics just released on the Lions Club's international website reveals that in the Africa region, approximately 32.7 million people have diabetes, with South Africa contributing 4.5 million cases to that tally. Global statistics reveals that 1 in 11 adults has diabetes around the world, with a high percentage going undiagnosed. Diabetes is therefore recognized as an important pillar of the Lions, and our organization's mission is to reduce the prevalence of diabetes and to improve the quality of life for those diagnosed. Raising awareness is key, and hence this webinar. Our keynote speaker this afternoon is esteemed Professor Joel Dave, who is the head of the Division of Endocrinology in the Department of Medicine at Groote Hospital and the University of Cape Town. Professor, we are honored to have you present here today. Thank you so very much for taking the time off your busy schedule. Welcome, Professor, and I'll now hand over to you. Professor Joel Dave.
Thank you very, very much, Niroshni, and thank you very much for the invitation to speak. It's a privilege to be here with everyone around South Africa. Our load shedding here has just started, so I'm hoping that everything will run smoothly. I just want you to confirm, can you see my full screen?
We can indeed. We can indeed. Thank you very much.
Just to confirm, Professor Joel, it is also it's the main focus of the recording at the moment. So that's what everyone will see when they watch a recording, is mainly your screen.
Great, thank you very much. So I'm going to start off, unfortunately, with my talk with the bad news. And as Niroshni introduced, unfortunately, the world is facing a pandemic of diabetes, with about 463 million people by 2019 known to have diabetes. And this has been estimated to increase by 2045 to about 700 million people. Now, if you have a look at all the times, these stats are produced by the International Diabetes Federation, and you can go to their website where they have a lot of information on diabetes. And each time they have the estimate, that number is unfortunately reached about 10 to 15 years prior to their expectation. So unfortunately, the pace of diabetes is increasing beyond what any known formula can predict. And a commonly quoted statistic is that 1 in 2 people who currently have diabetes actually don't know they have it, so they're undiagnosed. And most patients, unfortunately, especially in South Africa and Africa, but also in other parts of the world, aren't actually well controlled. And despite everything at our disposal, diabetes unfortunately results in quite a lot of deaths each year. You can see there in this graph here, I mean, on this slide, in 2017, there were 4 million deaths. And just to show you that in 2015, there were more deaths from diabetes than those from HIV, AIDS, from tuberculosis, and from malaria all put together. And consequently, you can see there in 2019, the huge financial burden of diabetes globally at $760 billion. Africa, unfortunately, if we just focus on Africa, is going to experience the biggest increase in diabetes over the next 2 to 3 decades. You can see although we're not going to have the most people with diabetes, we're going to have the greatest rise. So we're going to increase by about 143%. And you can see that exceeds any other region in the world. And unfortunately, South Africa is the leader. So if we have a look at Africa, South Africa has about 4.6 million people living with diabetes. And just to remind you what I said earlier, that the estimate is that 52% of people living with diabetes at this moment in time in South Africa don't actually know they have diabetes. So they are currently undiagnosed. Diabetes, if we have a look at data from Stats SA in 2016, diabetes was the leading cause of death in the Western Cape. Surprisingly, I know many people, this caught people by surprise, diabetes was the leading cause of death in women in South Africa. And if we have a look over in men, it's the second leading cause of death in men and women, just behind tuberculosis. But if you have a look over the years, it's slowly catching tuberculosis. And I wouldn't be surprised now, 5 years later from this data, that perhaps diabetes is actually now possibly the #1 cause of death in men and women in South Africa. We know that diabetes is associated with serious complications in many parts of the body, but especially the eyes, the kidneys, the heart, the brain, and the nerves. And the leading cause of death in both people with type 1 diabetes and type 2 diabetes, males and females, is cardiovascular disease, mostly heart attacks. But I want to now change to the good news. We started with the bad news, but there is some very good news. And the good news is that everything that I've said is completely preventable. So we have many diabetics that have been living with diabetes for the last 50 to 70 years. They're on insulin and they are complication-free. So with good control of diabetes, we have many large studies now showing that we can prevent everything that I've just mentioned about diabetes. And it's all associated with something called the HbA1c. The HbA1c is something it's a blood test that we do in people living with diabetes, and it tells us roughly what the blood glucose has been for the last 2 to 3 months. And it's all about ensuring that this A1C goes as close to 7% as possible. So this is what studies have shown us, that if we can get the HbA1c as close to 7% as possible, the risk of the complications in people living with diabetes are vastly reduced. So that's the good news. Just to remind everyone that there are a few types of diabetes. There's type 1 diabetes, type 2 diabetes, gestational diabetes, which occurs in pregnancy, and then all other causes of diabetes are put under one heading called other. But today I'm just mainly going to focus on type 2 diabetes. Now, if we have a look at the risk factors for type 2 diabetes, in general terms, there are 2 types of risk factors. There are risk factors that you can do nothing about. So they're non-modifiable, and those are your genetics, your family history, your race or ethnicity, your age, and whether you've had a history of gestational diabetes. So unfortunately, there's nothing we can do about those, but there certainly are quite a number of modifiable risk factors. So risk factors that we can focus on to decrease the risk of people getting diabetes. And you can see that 3 of them all go together. So physical inactivity, poor dietary habits leading to weight gain, overweight or obesity, that are the main drivers of our massive increase in the prevalence of type 2 diabetes at the moment. So much so that some people call it diabesity, because the two of them are so closely linked. So if we focus now just on obesity, and this I copied from the WHO website, and I think the bottom line in the middle there, obesity is preventable, I think is the key point. And you can see the numbers. I'm not going to read all of them out, but the numbers are staggering of the prevalence and the increasing prevalence of obesity globally. And I think the most telling statistic is this one here, that at the moment, unfortunately, there are almost 40 million children under the age of 5 who have been classified as being overweight or obese. And if you have a look at here in those over 5, but still in their teenage years, there's over 340 million people that were obese in 2016. And that's probably now, unfortunately, slightly worse. And so obesity is completely preventable. I'm just going to focus, because my heart is with South Africa, I'm going to focus on what's been happening in South Africa. And if we have a look at us in Africa, you can see that unfortunately, when it comes to our women in South Africa, and we look at overweight, we're the second most obese nation, overweight nation in Africa. Only Algeria is slightly higher than us. But when it comes to obesity in women in South Africa, you can see that we are the most obese nation in Africa. And unfortunately, when you compare us to the rest of the world, we are one of the most obese nations in the world. I know we like to think of the Americans as being the most obese nation, but unfortunately, amongst the women in South Africa, we do unfortunately rival the Americans with being rated as the most obese nation in Africa. And in the world. In our men, we are also the second most overweight and the second most obese in Africa, but not to the degree where our women are. So that puts about 19 million people in South Africa being obese or classified as being obese or overweight. And you can see this is some data from 2003. And then again in 2016, you can see that it's increasing, both overweight and obesity. And I suppose now, another 5 years later, we're probably even a bit higher, probably over there. Unfortunately, and one of the saddest statistics is our children. It's estimated that 1 in 5 children in South Africa, you can see here between 1 and 6 years in 2005 and here between 2 and 5 years is unfortunately overweight. Most of them overweight, but you can see that the obesity portion is also slightly increasing. So these are our adults and our health care for the future that are beginning their early years, unfortunately, being overweight or obese. And the biggest problem with being overweight or obese is that it predisposes to diabetes. So I'll speak you through this graph. You can see here is the body mass index, and this is the risk of becoming diabetic. And you can see here, let's focus on the woman. You can see that as the body mass index increases, the risk of diabetes increases, so that once you reach the obese range, which is classified as a body mass index over 30, it almost becomes logarithmic, the risk of developing diabetes. And similar in men, but to a lesser degree. And if we reverse this, the same is true. So if someone is obese and they lose weight, you can see that as they lose weight, their risk of developing diabetes actually decreases. So it's incumbent on all of us to ourselves ensure that we maintain a normal body weight, which is generally in the majority of us between a body mass index of 20 and 25, and that we hopefully promote it in our families and with our friends to hopefully drive a healthier South African nation. So as Naroshni said, this is World Diabetes Month, Diabetes Awareness Month, and on the 14th of November, there's World Diabetes Day. And the theme for Diabetes Day is access to diabetes care, if not now and when. So I think it's imperative on all of us, all community organizations, all those that can, to ensure that everyone we know that has diabetes or is at risk of getting diabetes essentially gets access to the appropriate care to either manage their diabetes or to hopefully prevent their diabetes. We're also in this year celebrating 100 years of insulin. The insulin molecule was discovered in 1921. This is a picture of Banting and Best, and this is one of the diabetic dogs in which many of their experiments are carried out. This is the laboratory in which insulin was isolated. And this, Leonard Thompson, in about 1922, 1923, was the first person to successfully be injected with insulin. You can see here a very concerned mother with a child with the classic signs of type 1 diabetes, severely dehydrated, emaciated, very ill. And this was Leonard 3 months later after being given insulin. So you can see insulin is a fantastic molecule. It saves lives, and it's fantastic that we've now celebrating 100 years of insulin, and it's that molecule itself has saved many thousands to millions of lives. Luckily now the delivery of insulin has improved. These poor Leonard wouldn't have been injected with a very small needle and a pen. He would have been injected with a thick syrupy type of liquid with a thick needle that would have caused quite a little bit of pain and tenderness and redness around the injection site. Luckily now things have progressed over the years from syringes that they are still actually used in the state sector to wonderful insulin pens that now improve the delivery of insulin, and now to the lucky few who can afford it, insulin infusion pumps, just another modality of injecting insulin. We're also lucky enough to have a variety of insulins that have progressed over the years, from animal insulin to human insulin to analog insulins, within each time an improvement in the function of the insulin. We also now have wonderful ways of monitoring the blood sugar. We have a variety of glucometers, and now that's newly hit the market in the past couple of years are continuous glucose monitors, of which we have access to 3 types in South Africa. Unfortunately, all of them are still quite expensive, so they are not accessible to the average person, but we're hoping with some strong advocacy that the prices will drop, and that many of the people living with diabetes in South Africa will have access to this technology. Just to focus on also on the drugs to treat type 2 diabetes, for many years we only had 3. Then in the early 80s, there were another 2 classes, but just to reassure everyone that there's such fervent research in this field that over the last 2 or 3 decades, we've had an unbelievable increase in the number of classes of drugs that we have to treat type 2 diabetes. So I think in the future, there's lots to look forward to in the treatment of diabetes. There are a number of wonderful insulins, wonderful ways of monitoring glucose, lots of ways of helping people with type 2 diabetes to control their glucose readings, and hopefully in the not too distant future, maybe even a cure for especially type 1 diabetes, and hopefully also type 2 diabetes. So I'm just going to end off by giving just some general advice to those who do have diabetes. I think what's very important now is to realize that you're not alone. It's very important to surround yourself with a multidisciplinary team. If you have access to the public sector, this team is available. And if you have access to healthcare in the private sector, your medical aids are compelled to pay for your access to this multidisciplinary team. And just to remind you that you are the boss, you are the captain of this team, and everyone else is working for you and with you to improve your outcome and to improve your quality of life. So it's very important that you make use of everyone in this team to ensure that you get the best care that you think you need and that you require at that time. Another caution is just beware of the internet and social media. We now know that information is widely available. Some of this information is excellent, some of it is not. So it's very important to make sure that the sites that you visit and the information that you take note of is scientifically evidence-based medicine, and that everything that is said is backed up by good scientific data and that it comes from a reputable source. Another thing that I find with patients, please always tell your doctor the truth. Remember, your doctor's not a policeman, your doctor's there to help you. And I know often the diabetics that come to our clinic at Groote Hospital, they often want to tell us what they think we want to hear, but it's very important for your own health and to ensure that you get the best quality of care, to tell your doctor the truth, to tell your doctor the problems, so that all that energy of the consultation can be focused on helping you. And lastly, to end off, just remember it's never too late. If you have been diagnosed with diabetes and you haven't really been controlling it, we have lots of data now to show that it's never too late to start controlling your diabetes. We have lots of data to show that if someone already has complications from diabetes, good control can delay or prevent the progression of those complications. So at all times, all of us together have to strive to improve diabetes control. So I think that's all I have to say. I'm very happy to stay at the end and answer questions and discuss. And I'd like to thank everyone once again for in the invitation, and thank you very much for listening.
Thank you. Thank you so very, very much, Professor, for your wealth of knowledge, advice, and expertise that you've shared with us this afternoon. We are truly blessed to have a person of your caliber on this webinar, and you have given us so much to consider and to process for our respective organizations to take forward to assist our communities in our various areas. So thank you ever so much, Professor, and I'm so grateful to have you remain till the end to take questions. Thanks again.
Thank you.
I would like to now introduce you to a lovely young lady, UMIKA NATHOO, a 16-year-old grade 11 student who will share her journey on how she has managed her life with diabetes. Over to you, UMIKA, and thank you for taking the time in between your exam preparation to share with us today. Welcome, UMIKA.
Hi, thank you. So my name is UMIKA NATHOO. I attend Thomas More College in Durban. I am 16 and turning 17 in December. I was diagnosed with type 1 diabetes when I was about 3 years old, but this has never actually stopped me from achieving my goals and dreams that I put my mind to. I play a lot of sports. I'm in the softball, golf, and netball team. And I even took part in a 55-kilometer walk with my school, even though my mother and my doctor were awfully worried about me taking part because of my diabetes. I ended up proving them wrong that I could do it, and I finished the whole 55 Ks. And this just proves that diabetes shouldn't stop you from doing things that you're really passionate about. And even if other people are there telling you that maybe not do it because you are diabetic, if you put your mind to it and you do manage your diabetes and control it along the way, you will be able to achieve anything. I gym every day for 2 hours with my brother. I do a lot of cardio, weightlifting, swimming, running, and boxing. So I do manage all of my intake for fitness and all of that. And some days with diabetes are going to be much, much harder than others, but there are always going to be better days than the bad days. And these hard days where you feel that everything's just too much and you can't handle it, it's just going to make you stronger and teach you how to go forward in the future when you have another day like this. So diabetes should never actually stop you from achieving your dreams and your goals, because whoever is diabetes type 1, type 2, whatever, you are stronger than you think and you are more capable than you believe to achieve what you put your mind to. And also, you're not alone in this. No matter what, there are so many people who support you and are willing to help you. You just need to actually go and ask for help. Some people believe that asking for help makes you weak, but that's not true at all. It's actually going and asking is what makes you stronger, and it will help you in the future. To end off, I'd just like to have a quote by Eleanor Roosevelt. It says, "The future belongs to those who believe in the beauty of their dreams." And this just emphasizes that, yes, we all are different, but that's what makes us human beings and who we are. And all the diabetic people shouldn't let anything stop them from achieving their dreams and goals. Thank you.
Thank you so very much, UMIKA. Thank you very much for your positive and inspiring message. I am sure it will indeed benefit many, particularly young people who have going to have access to this webinar. UMIKA, I do know you need to leave the webinar to resume your online tuition. And thank you, and the very best of luck for your exams, sweetheart. Thank you again.
Thank you so much. Thank you.
Okay. My co-host from Diabetes SA, Pranisha Deonarayan, is a nutritionist, and she is a diabetes educator, and she has assisted us Lions with her wealth of experience on the topic. And I will now hand you over to Pranisha, who will introduce herself and our next esteemed speaker. So over to you now, Pranisha. Thank you very much.
Thank you, Niroshni. Welcome, everyone. I have great pleasure in introducing Dr. REYANTA BRIDGMOHUN, who is a specialist psychiatrist. And Dr. BRIDGMOHUN has a diploma in mental health. She has fellowship in the College of Psychiatrists and a Master of Medicine in Psychiatry. Dr. BRIDGMOHUN is in practice for about 6 years now and qualified at WITS. She has recently relocated about 2 years ago to KZN. So I now hand you over to the capable hands of Dr. BRIDGMOHUN.
Good afternoon, everybody. Thank you again for allowing me the opportunity to speak today. As Pranisha says, I am Dr. REYANTA BRIDGMOHUN. I'm one of the psychiatrists here in Johannesburg. Initially from Johannesburg and now practicing in Pietermaritzburg. So with regards to diabetes and mental health, so diabetes is an increasingly common health problem. Non-communicable diseases, including diabetes, have shown to have a definite negative psychological impact on patients and families. Diabetes is a burdensome condition that significantly reduces quality of life, and patients living with diabetes requires psychological support throughout their lifespan. Psychological makeup plays a role in managing themselves and the illness. Personality characteristics can have both a positive and negative impact on self-management, especially when it comes to diabetes. Non-adherence to treatment results in suboptimal disease control of disease, increased diabetes-related complications, and results in increased healthcare utilization, and as a result, an increased burden on healthcare systems. Psychological support may be insufficient due to the increased pressure as well as lack of availability. Diabetes also poses a high risk of decreased psychological well-being, which may be already present in approximately 50% of patients at the time of diagnosis. Diabetes has a negative impact on patients' lives, including relationships with families and friends, physical health, medication effects on life, and negative coping strategies. Untreated social disorders result in increased physical symptoms, cardiovascular complications, as well as depression. Depression may lead to cognitive decline and further aggravate the vicious cycle of the ability to take care of the self. Comorbidities associated with diabetes include both physical and psychological, such as depression, anxiety, which are common amongst patients with diabetes. Patients with both type 1 and type 2 diabetes are 3 times more likely to develop depression compared to people without diabetes. And approximately 30% of children who have diabetes have symptoms of depression. Mental illness associated with diabetes include diabetes distress, depression, severe mental illness such as schizophrenia and bipolar disorder, as well as anxiety, eating disorders, dementia, adjustment disorders, and phobias. And to top it all off, we do have stigma and discrimination towards patients with mental illness. Indications for psychiatric evaluation in patients with diabetes include an evidence of a depressed mood, a low body mass index, which may indicate an eating disorder, the reluctance to start insulin therapy. This may also indicate needle phobia, persistent suboptimal glycemic control, and recurrent admissions either due to diabetic ketoacidosis or recurrent severe hypoglycemia, and difficulties in transitioning from the child clinics to the adult clinics for diabetes care. Diabetes and depression has been shown to have a bidirectional relationship. Depression diagnosed before the onset of diabetes has an increased risk of developing type 2 diabetes in later life. Likewise, the development of type 1 and type 2 diabetes confers an increased risk of developing depression. Increased depressive symptoms or untreated symptoms has been shown to be linked with poor glucose control, as well as increased diabetic-related complications, poor diabetic-related behaviors, and an increased functional disability and an increased risk of earlier mortality. The prognosis of patients with comorbid depression and diabetes is worse when each illness occurs separately. Episodes of major depression in individuals with diabetes are likely to last longer and have an increased chance of recurrence compared to those without diabetes. Risk factors for developing depression in patients with diabetes include female gender, adolescents and young adults, as well as older adults, patients who come from a background of poverty with few social supports, additional stressful life events, poor glycemic control, particularly with recurrent hypoglycemia, the longer duration of diabetes mellitus, as well as presence of long-term complications. The possible mechanism for developing depression in patients with diabetes include physical inactivity and obesity, which leads to insulin resistance, psychological stress, leading to chronic hypothalamic pituitary adrenal activation with cortisol release. Patients with diabetes may develop depression because of increased burden of disease or associated biochemical changes. Patients with depression have a poorer clinical parameters due to difficulties in maintaining behaviors such as increased physical activity, a healthy diet, and medication compliance. Depression may be both a consequence and a risk factor for diabetes, and concerns about maintaining normal glucose levels, medical complications, episodes of hyperglycemia, and other characteristics of diabetes. Diabetes distress is a range of negative emotional states that arise from diabetes morbidity and self-care. It's not the same as depression, and it's more an emotional reaction that may include fear, worry, anger, guilt, sadness, or frustration, or burnout. Depression and diabetes distress can exist simultaneously and independently in the same individual, and is an emotional response to the challenges posed by diabetes, which may include emotional reactions. Whilst depression includes significant cognitive, affective, social, motivational, and vegetative disturbances, the management of diabetes stress is very important to ensure adequate glycemic control, medication adherence, improving quality of life, self-efficacy, and improved negative healthcare behaviors. So the link with depression and diabetes, and if this is adequately managed with diet, exercise, medication adherence, and sleep, can lead to better outcomes for our patients with diabetes. Diabetes and anxiety share common comorbid with depression symptoms. Adults and children with diabetes have been found to have elevated rates of anxiety symptoms, including other anxiety disorders. Studies have shown higher rates of anxiety that is specific to living with diabetes and diabetes-related complications, for example, the fear of needles or the fear of hypoglycemia. There's also a link between developing type 2 diabetes and having post-traumatic stress disorder. Anxiety is associated with poor diabetes self-management behaviors, decreased quality of life, and higher HbA1c levels. The fear of needles and hyperglycemia has a significant negative impact on self-care activities, intentional omission of insulin, or underdosing to prevent low blood sugar. The fear of needles affects monitoring of glucose, as well as the fear of insulin injections. Both type 1 and type 2 diabetes is associated with cognitive dysfunction in older adults. Majority of individuals with diabetes show similar cognitive abilities to those without diabetes. Patients with diabetes have a 73% increased risk of developing dementia. Studies have shown an 127% increased risk of vascular dementia and 50% increased risk of Alzheimer's in patients with diabetes. Diabetes is also associated with a higher risk of mild cognitive impairment, which is a stage of cognitive decline before cognitive aging, and milder cognitive aging and dementia. Children and adolescents, as well as young adults with type 1 diabetes, have found to have mild decrements in their abilities, in cognitive abilities and information processing speed. Middle-aged and older adults have shown changes in fine motor skills, executive functioning, which includes working memory, planning, focusing, and remembering instructions, as well as flexible thinking and self-control, as well as the speed of information processing, which is the ability to automatically process information, and verbal memory and visual memory. So verbal memory refers to the memory of words, abstractions, and involving longer abstractions. And visual memory is the ability to remember, recall information such as activities, pictures, or words that have been viewed in the past. Poor performance in instrumental activities of daily living, which is activities regarding self-care, taking care of the home, has been associated with cognitive dysfunction and processing speed. The accuracy and reliability of diabetes self-management can be impacted on by cognitive decline, including information processing, fine motor skills, memory, and executive function. Cognitive dysfunction sometimes presents as patient self-reported concerns about changes in thinking, family-reported concerns, or changes in activities of daily living, diabetes self-management, or even changes in the patient's mood and personality. Diabetic patients have been found to have a higher risk of suicidal ideation, attempted suicide, and completed suicide. The prevalent rate of suicide in patients with diabetes is 16.2% compared to rates of 9.2% found in the general population. Increased rates of suicide in patients with diabetes has been linked with the comorbid diagnosis of major depression. Suicidal patients with type 1 diabetes may avoid taking insulin or use excessive doses of insulin as a method of self-harming. Risk factors for suicide include overwhelming feelings of burden of disease, taxing diabetes care, financial costs, poor quality of life, a deterioration in personal relationships, as well as negative cognition such as constant worry, hopelessness, and poor prognosis. These are some of the warning signs related to patients who might have some suicidal thoughts, including a negative view of the self, making suicidal threats, substance abuse, giving away things, making funeral arrangements, engaging in risky behaviors, self-harm such as cutting, A sense of hopelessness or no hope for the future, isolating or feeling alone, aggressiveness and irritability, possessing or thinking of lethal means, feeling like a burden, drastic changes in mood, or also even frequently talking about death. Patients with serious mental illness, such as schizophrenia, spectrum disorders, or bipolar disorder and major depression, have been shown to have a reduced life expectancy of between 10 to 25 years. This has been linked to the increased risk of cardiometabolic disease, and persons with severe mental illness are 2 to 3 times more likely to develop diabetes than the general population. There's a significant stigma that is placed on patients with severe mental illness by the general public, individuals themselves, as well as healthcare workers. This may result in the failure to acknowledge the need for help. Stigma in healthcare workers can result in unequal provision of diabetes care to patients with severe mental illness, including education and diabetes. Patients with severe mental illness show higher rates of diabetes as well as a result of metabolic side effects of psychiatric medication. So importantly, in the last 2 years, we've been dealing with COVID-19, and this has had a unique impact on patients with diabetes mellitus. Clinical aspects and self-care of patients with diabetes have been negatively impacted on by the restrictions on travel and movement, as well as generalized anxiety around the pandemic. Restrictions on access to medical services, doctors' consultations, treatment and monitoring, as well as outdoor physical activities cause additional stress on these patients. This has resulted in poorer clinical outcomes in patients with diabetes, including ICU admissions. The fear of increased mortality and poorer outcomes in diabetes patients has exacerbated pre-existing diabetes distress as well as mental health issues. So quality of life refers to patients of sense of well-being, and diabetic patients face challenges with physical, emotional, psychological, social, occupational, and interpersonal levels, leading to reduced quality of life. Patients with diabetes are faced with overwhelming concerns regarding monitoring and maintaining blood glucose levels, use of anti-diabetic treatment, the fear of hypo or hyperglycemia, medical complications, psychiatric complications, the obligation to exercise, food restrictions, financial implications, as well as decreased social interactions. Focus should be on improving quality of life by reducing overall disease burden, access to medical care, educational and psychological interventions, as well as diabetes support groups. In trying to assist our patients who have diabetes and additional mental illness, some psychiatric interventions, which are age-appropriate screening measures for use by non-mental health professionals, such as the Patient Health Questionnaire, a Child Depression Inventory, and the Geriatric Depression Questionnaire. Also optimizing biological treatment of their diabetes, as well as biological management of comorbid psychiatric conditions where indicated. Specific psychological therapies, including cognitive behavioral therapy, behavior activation, as well as psychoeducation and motivational interviewing, will assist our patients with diabetes in identifying when they have severe mental illness and then supporting them to access psychological and psychiatric care. Thank you again for the opportunity for allowing me to speak today. I will also remain until the end if there is any questions.
Okay, thank you very much, Dr. BRIDGMOHUN. You have definitely helped all the doctors, dietitians, podiatrists, nutritionists on this panel to actually have a bigger, better picture about treating our patients. Thank you once again. I'd now like to introduce our next speaker, who is a podiatrist, Ms. VUYELWA MPALA. She has a BSc Honors and is a member of HPCSA, PASA. She is an avid, very active Diabetes SA member, as well as plays a part in CDE. Ms. MPALA has 19 years of work experience, and she has worked both in NHS as well as the private sector. She has a special interest in the diabetic foot and wound management. I now hand you over to Ms. MPALA.
Hello, everyone. Good afternoon. Thank you so much for the introduction. I'm just going to briefly explain to you how diabetes impacts the feet and what role podiatrists play in the feet. Okay, this is roughly my first time doing this. So can you see my screen yet?
Not yet, Ms. MPALA. Something coming up, just a moment. Yes, there's your screen now.
Okay, so it's basically about diabetes and your feet. Okay, so we use these controls. I'm going to introduce how podiatrists impact patients and their feet. There are two components that affect the feet. It's the circulation and the nerves. Okay, and then I'll go into detail about how that, how it affects the feet, and then just give some pertinent advice on that's important for patients to know to improve their feet and the quality of life. Statistics as given by the first speaker, Professor Dave, are roughly the same. Basically, if you think about the total population in South Africa, about over 35 million. And of that population, there's a 12% of the adults are diabetic, which is a rise from the previous of about 9.2%. Total cases of diabetes in adults is about over 4.5 million. In KZN, we have a population of about 11 million, and specifically in Pietermaritzburg, where we have 1 million. So they're quite high numbers. I didn't manage to get exact numbers of how many diabetic they are in Pietermaritzburg. But if you think about it as well, diabetes is the second leading cause of death. This is between 2015 to 2016. So it's a significant number. It's a significant illness to have, and it's important to have to be educated, not just educating the patients, but educating the family around patients so that they know how to control their, knowing the importance of diabetes, how to control it, and everything surrounding diabetes to improve their quality of life. As has been said, my statistics say about 62% undiagnosed diabetics, which is a significant number, considering if you're not aware that you're diabetic, that increases your risk factor of developing complications as a result of the high sugar levels. And people are unaware of the treatment methods that are available for them to improve their prognosis. Okay, so we'll go into the role of a podiatrist. A podiatrist is a specialized allied health professional who assesses, diagnoses, and treats lower limb conditions. And its role is of utmost importance in saving the diabetic limb. Firstly, diabetic foot education is important. Patients' knowledge of their condition impacts how they view things, what they make important in their life. So if they're educated and they're aware of what state they are fit in, it better improves how they respond. Podiatrist knowledge of biomechanical discrepancies and pathogenesis of diabetes enables them to prevent, treat alteration in the foot. Also, prevention strategies employed by a podiatrist include regular checks, regular reduction of calluses or corns, treatment of nail pathologist, for example, nail surgery for ingrown toenails. We provide orthotics or shoe inserts for biomechanical problems. And we play a very important role in detecting serious pathologies such as the Charcot foot or skin conditions. Skin conditions, for example, tumors are easily recognized because we know what to look out for. The aim is to have regular foot checks, which is important in preventing ulcers, amputation, and ultimately improves the patient's quality of life. Research shows that amputations are prevented by about 80% when a diabetic patient sees a podiatrist regularly. Regular foot checks should be done at least once a year for low-risk patients. I'll explain to you what the low risk and medium to high risks are, and more frequently for medium to high risks depending on their foot pathology. Okay, the first thing that we test is their circulation. Now, circulation is the arterial supply to the foot. That's the most important part that we test, because you need good blood supply to the foot for basic foot function, such as obviously walking. And then also, if in case a patient gets cut, bruised, you need a good arterial supply in order to heal that. The two pulses that we test are the dorsalis pedis and the posterior tibialis. In the diagram, it shows that's the dorsalis pedis, and then behind the medial malleoli, that's the posterior tibialis. We usually use the Doppler to test these pulses. You get 3 different types of pulses. You get the monophasic pulse, biphasic pulse, and triphasic. Monophasic is a bad pulse, unfortunately. Usually it's either monophasic or no pulse at all. If there's bad circulation, in that case, that's called ischemia. If it's biphasic, the average population has a biphasic pulse, and triphasic is usually young children and athletes who tend to have triphasic pulses. Now, you also get triphasic pulses, unfortunately, in patients who are neuropathic. And the reason for that is disruption of the nerve functions in that case. Okay, just thought this would be an interesting diagram to show you about the atherosclerosis complications, which is basically leads to ischemia. Ischemia is reduced circulation to the feet. That's a good artery with a little bit of black. You can see how wide it is. As time goes on with a diabetic patient, the high levels of sugar destroys the walls of the arteries, weakening them, therefore making it easier for plaques of cholesterol to deposit on the inside of the artery. When that happens, it thickens and thickens. And then this just shows you one of the plaques that's ruptured. When this happens, obviously blood clots happen, therefore further reducing limiting blood flow through the arteries, sorry. Okay, and in this case, in most cases, in this case, that's where you hear the monophasic pulse or no pulse at all, depending on what it looks like. Now, an ischemic type of foot would be a foot that looks pale or dull, has no hairs because it doesn't have enough nutrients applied to nourish the hairs, has inelastic skin. So basically, the skin is not supple. You have a mottled color. Now, in Caucasian skin, you would see a mottled color, which is a purple-blue color, whereas in black or people of color, you would see a darkening of their skin. Okay, and they also get pain. The pain in really bad ischemia is a constant pain in their feet, and only surgery can improve that condition. As explained, results of ischemia means that you have delayed to no wound healing at all, and therefore it's important at this point to make sure that the patient has vascular intervention. Vascular intervention will also depend upon the patient's status, medical history. in most cases when patients are ischemic, they're old and frail and have different complications. And therefore it's up to the vascular surgeon to decide whether vascular surgery is appropriate in that case. But wound healing happens when you have enough blood supply. And it's important, that's why it's really important to get education out to the patients before they get to a state of bad ischemia, so you to prevent amputations. And then it's also known that once patients get to states of amputations, has amputations, it reduces their quality of life and unfortunately also increases rate of mortality. Okay, I just thought it would be interesting to point out that the recent research has shown that the COVID toes, in COVID toes, you get blood clots. That's blood clots to the microcirculation, and that's manifest as swelling, blisters, bruising. You may also get an itch or pain in it, or a rash, and it mainly happens in the toes. So if you come across a patient with this, the COVID toes, the main thing is to encourage them that it's most likely to go on its own as the circulation improves. They may take blood thinners, depending again on their medical history. And hydrocortisone cream may help as well. If their situation's really bad, they could seek dermatologist advice. Exercise obviously just helps improve circulation. Okay, and then going on to nerves, we test the nerves as well. Nerves, with nerves, you get neuropathy, which is basically nerve damage. And this is a diagram that just explains how the neuropathy happens. Now, you could have good circulation and neuropathy, but when you get neuropathy, it's about the microcirculation, that's the blood vessels that actually supply the nerves that get dwindled off. And this shows you one with good circulation, the circulation slowly going, and then that's one that's totally nerve damaged. We test the nerves using the standard tests, which are the 10-gram monofilament and the 128 Hertz tune-in fork. It's also standard to test ankle reflex, but then that can be quite complicated for different reasons, because the standard reflex can go for several other reasons as well. There's the large nerve fibers as well as the small nerve fibers, which we test. The large nerve fibers will be related to touch, vibration, position, perception, and muscle control. And then small nerve fibers would be the thermal perception, pain, and autonomic function. There are different stages of neuropathy. In stage 1, it says that no signs or symptoms. Now, this is usually when nerve damage happens to the microcirculation. Nerve damage happens silently, and then right before that, it goes on to stage 2. I found that initially, when patients have high sugar levels, the first warning symptoms are numbness, as in the diagram here. You get numbness, you get pins and needles, you get burning sensation, you get shooting pains, and sometimes patients experience like a cotton sensation in their feet or a tightness in their feet for no reason. And these are warning symptoms that their sugar levels are high. They need to bring their sugar levels down, and when they do that, then the symptoms disappear. However, if this goes on for a long period of time, unfortunately, it's not reversible, and then they have to start taking pain medications to counteract that. We normally advise them to start off with the herbal type medications. I'm sure you've heard of superfoods such as moringa. Moringa is one really good one, which has been shown to help with neuropathic pain. There's vitamin B12, neurobion, which also helps in some cases. And the next stage would be taking neuropathic pain medications such as Cymbalta, pregabalin, which I try to, I make sure I emphasize to patients that they don't want to get to the stage of taking the pain medication, because they have to, when they get to that stage, they'll have to titrate their medications up every year, because the symptoms just get worse and worse. The most important thing for the patient to do is try and focus on controlling their blood sugar levels, so that's to work with their physician to help reduce their blood sugar levels, and then I'll explain the rest later. When it gets to stage of ulcers, deformities such as Charcot foot and amputation, that's stage 3, and that's when you've lost sensation to 10-gram monofilament test and the vibration test, and patients are basically unable to feel stimuli and therefore are more prone to excessive pressure, or not when you don't feel anything on your foot. If you do get any cuts or bruises, you don't check your foot or you don't look at your foot, so you don't do anything about it, and in that case you get infection. So when it gets to the stage of ulcers, there are different factors that you then need to start considering in order to heal the ulcer. One of the pressure, an ulcer does not heal if it has pressure on it, or it takes longer to heal, and you find that with neuropathic ulcers, patients get a lot of callus. When they get a lot of callus, that also hinders the healing process. So all those things need to be addressed with patients that have got ulcers on their feet. Therefore, it's important for them to see a podiatrist. The Charcot foot is an interesting foot. It's as a result of neuropathy. So basically, no nerve function, feeling in your feet. Now, this is a foot of a healthy foot. And then this is a very, and I chose a nice picture. I should have really shown you the gruesome picture, but this is a nice picture of what a Charcot foot looks like. The midfoot is the part of the foot that's affected. This gets red, swollen. You don't, the patient generally doesn't feel any pain. And at the advanced stage, this area becomes very mushy. It looks mushy on the x-rays. And when it gets to that stage, deformity happens. So basically, a patient who has a Charcot foot, it's good to recognize this in the initial stage, which is the redness and the swelling, and then put the patient in the moon boot. When they're in moon boot, it keeps their foot in a stable position to prevent this from happening. So you have flare-ups. When it flares up, that's when deformity is likely to happen, and then it calms down. When it calms down, the bones set. So it's important during the flare-up positions for the patient to be in a moon boot that's immobilized. Unfortunately, not much can be done except for that, and to manage the swelling that the patient gets. Okay, so after the tests, the assessment that I've just explained that we perform when the patient comes in, and explain that to the patient, we explain to them that good blood glucose level control is very important. Exercise helps not only to reduce blood sugar levels, but also to help the muscle pump. If you think of it, your feet are the furthest away from your heart. So therefore the blood doesn't flow as effectively as it does closer to your heart. So we advise them that walking in particular, walking in a big good pair of shoes that allows motion in your foot, helps with your muscles to help pump the blood, basically squeeze the arteries. Not only does it help with the arteries as well, but it will also help with the veins, so that's venous return. Okay, we advise them to eat healthily, as you know, eating over processed carbohydrates. The dietitian would explain. We advise them to make sure that they at least have seen a dietitian. High carbohydrates will contribute to overprocessed large amounts of carbohydrate will contribute to high sugar levels, and also certain types of fats will clog up your arteries. So we advise them eating is important, eating habits is important. For them, we also advise them to develop good habits. Now, it's better to prevent than to cure. So developing good habits would be your daily foot checks. If when you're healthy, you have a habit of checking the soles of your feet, checking your feet for any cuts or bruises, should you develop any complications, you already have a good habit, which will help prevent you from getting ulcers or bad ulcers. So you notice a cut or a bruise as soon as it happens, and you do something about it. We generally advise them to make sure that they clean it with an antiseptic, any open wounds, cuts, clean with an antiseptic, and put a clean plaster on it, and repeat that process every day until it's completely healed. If it gets worse overnight, they need to see a podiatrist. If it takes longer than 5 to 7 days to heal, they need to come in and see a podiatrist so that all the other factors towards wound healing is addressed. Check their footwear. Always tip your footwear inside out. Wear the right type of shoes. Check water temperatures, because with neuropathy, you may not feel very hot. You may also not feel very cold, and extreme temperatures can lead to skin burns, which lead to ulcers. Okay, that's about it for my presentation. Thank you so much for listening. That's references if anybody's interested. Thank you.
Thank you so much, VUYELWA, for sharing your knowledge with us. I think you have just reinforced the importance of a multidisciplinary team in the patient care. And thank you very much for your information that you have shared. I now go back to Niroshni, who will continue with the program.
Hi, I just want to thank Dr. BRIDGMOHUN and Ms. MPALA for sharing your wealth of knowledge. We are ever so grateful. I know, apologies, we are running a little bit over time, but we have 2 more speakers, and I think the wealth of information shared is really worth waiting till the end of this webinar. It now gives me the greatest of pleasure to introduce to you our very own lion, Carol Brown, who is a registered nutritionist and has worked in the field of dietetics and nutrition for 35 years. She is passionate about helping people understand key aspects of healthy eating and works as an independent consultant on nutrition locally and in several countries on the African continent. And she is a lion, and we're very proud of her, and she serves as our district chair for hunger alleviation. Over to you now, Lion Carol Brown.
Thank you very much. Thank you for the opportunity to be here today and for the introduction. I'm going to screen share, which I hope is going to work.
I think, Carol, while your screen comes up, you might want to turn your camera off. It looked a little jumpy. It might be a bandwidth issue that might be smoother without it. I think we possibly might have lost Lion Carol there. Carol, you still with us? It looks like Lion Carol's just disconnected. I assume she'll be attempting to reconnect.
Okay, so Kim, do you think perhaps it might be advisable to move on to the next speaker while Carol gets herself sorted out?
Yes, I would suggest that would make
Yes.
probably the best
all
sense.
right. Absolutely. So it gives me great pleasure to introduce who is going to be our final speaker, Sister ELSIE NAICKER. And Sister NAICKER is a diabetes nurse practitioner working in the field of diabetics from 2006. She is so very well known and recognized for her sterling commitment as a diabetes educator. So over to you now, Sister ELSIE.
Thank you, Niroshni. I'm going to share my screen now.
Giving it a moment. I'm sure it'll show up in a second.
Jim, can you see my screen?
Not yet, but it can take a second or two for these things to catch up.
Okay.
So just give it a moment.
Okay. So I can see it, but now, can you see it?
There's still a black screen on our side.
Okay. I'm just thinking maybe you can.
Yes, I can do that for you if you'd prefer. That would be easier. Let me just fire up the screen share on my side.
Okay, I've got the share here.
So something's happening. There we go.
Can you see it?
We can see it. It looks like the email to the link you have at the moment. There's the PowerPoint firing up. There it is.
Now can you see it?
Now we can see it. That's the slideshow up and on display.
Okay, great. Thank you, Niroshni, and thank you for inviting me to speak in this very important month.
It is a pleasure, ELSIE.
Yeah,
It is a privilege to have you.
Yeah, so my topic is actually the World Diabetes theme, access to diabetes care, if not now, when? And, I think this is very important because it gives the National Health Department enough time to improve services to people with diabetes, because it starts now in 2021 and there's a run-up for this theme right until 2023. So when we look at this comment from the IDF president, Professor Andrew Bolton, he says, as the world marks the centenary of the discovery of insulin, I wish I could report, witness some decisive action to turn the rising tide of diabetes. Alas, I cannot. And this sounds like, a concerning comment, but somehow the World Diabetes theme of access to diabetes care gives us a glimmer of hope that together, diabetes educators, people with diabetes, the most important people, and the people that make our policies will make some great inroads in the next 3 years. So what I'm going to talk about today is a little bit about the role of the diabetes educator with regards to diabetes self-management education and support, and what diabetes educators and people with diabetes can do, and what role we can play to improve the services with regards to diabetes to people with diabetes. And also the most important thing is that people with diabetes have the power to make changes in their daily lives, to manage their diabetes, and have a good quality of life. And most importantly, the power to get government to make changes to improve services for them. And the World Diabetes theme says that it's giving all governments in all countries the opportunity to start making changes, to start improving services, to start improving the health of our people with diabetes, because it's a long overdue. Okay. At the moment, the public sector, there's no diabetes educator services in most provinces. A few provinces are privileged to have the services in the public sector, but most of the provinces do not. Okay, so who are the diabetes educators I'm talking about? The following professionals can be diabetes educators: nurses, dietitians, podiatrists, biokineticists, some pharmacists, GPs with diabetes interest, and also our endocrinologists. But remember, when it comes to our GPs, our endocrinologists, they do not have that time in their consulting room to educate patients, to spend that 1 hour that diabetes educators do. So most of the diabetes educators, sadly, are in the private sector. But the majority of our people with diabetes attend public clinics and hospitals. Okay, so it's the people with diabetes, diabetes educators, GPs, endocrinologists, and other interested persons who must take up the task of advocating for improved services for people with diabetes. And as diabetes educators and diabetes nurse practitioners, we know that diabetes self-management education and support can be a path to a better quality of life for the person with diabetes. We all know, and we've heard the other speakers before myself, speaking about diabetes as a complex condition that requires self-management on a daily basis. And patients have to make healthy food choices. They have to stay physically active, monitor their blood glucose, and take medication as prescribed. It also includes problem solving, reducing risks for complications, and coping with lifestyle changes. But what are we advocating for? And as I said, the next 3 years, right from 2021 right through to November 2023, what we'd like to see is that all patients, not just some patients in the private sector, but all patients in the private and public sector, to have access to diabetes self-management education and support, and also have access to a podiatrist, dietitian, eye specialist, and also the other, I haven't mentioned the other members of the team, but there are many members, and we heard the psychiatrist speaking. Psychiatrists, psychologists are very, very important to the person with diabetes. And diabetes is largely a condition of self-management. The people with diabetes have a great deal of power over the condition if they learn techniques to lower blood glucose levels. So let's talk a little bit more about diabetes self-management education and support. Diabetes is challenging to manage. You are expected to eat a healthy and balanced diet, plenty of physical activity, monitor your blood glucose throughout the day, take your medications as prescribed, and do all of this to reduce your risk of complications. At times, it might seem overwhelming, but you can manage your diabetes with the assistance of a diabetes educator and the other team members. Successful self-management will help you to deal better and can reduce your chance of developing complications like heart disease, a stroke, eye disorders, kidney disease, and nerve damage. And remember, it is possible to prevent complications. It's possible to stop the progress of complications. So the importance of screening is very, very a thing that should be done every time you see your GP. The diabetes educator will guide you through your treatment and help you with any fears, issues, and problems you encounter along the way. The diabetes educator develops a management plan that fits with your lifestyle, beliefs, and culture. Many times I hear patients saying to me, you know, I don't think you can help me because I can't afford the food that a person with diabetes must eat. And I eat, with the Indian culture, I eat curries. And I know with diabetes, I shouldn't be eating curries. And all those are myths. And therefore, it's important to have a good understanding, a good knowledge on how to prevent diabetes. And remember, the person with diabetes is the expert because they are living with diabetes on a day-to-day life. in their day-to-day life, they're living with the diabetes. So we are there to support you and guide you, but it's important for you to become as knowledgeable as possible. And we help our persons with diabetes to understand how to use the devices like the meters, insulin pens, insulin pumps, continuous glucose monitoring devices, and use the information from these devices and your lifestyle to identify patterns and opportunities for improvement. And you'll work together, with the person, with the diabetes educator to find solutions to address your most pressing challenges. And most of the time, we want our people with diabetes, our persons with diabetes, to find the solution, because when you find the solution, you'll be able to overcome the challenges. But if you find when the educator or your doctor says, do this, do that, and if you're not okay with that, you will not do that. So look at what you're okay with, what you can do to overcome the challenges. Diabetes education provided by a diabetes educator can help people with all types of diabetes to better manage their blood glucose, develop coping skills to address the daily challenges of the disease, reduce the risk of complications, decrease costs by reducing or eliminating the need for medications and emergency room visits. So remember, diabetes is a very, very expensive condition if it's not managed in the way it should be. And research has shown that people with diabetes that are guided and supported by diabetes educators have improved their blood glucose levels, and also have improved HbA1c levels, which is your 3-month average of your blood glucose level, and their general well-being. They learn about early signs of potential complications, and this can help the person with diabetes to ward off more serious consequences. Diabetes educators also run support groups. They participate in World Diabetes Day events and activities, example, the annual diabetes walk. They do blood glucose screening and educate the public on diabetes and diabetes awareness generally. And diabetes educators manage their people with diabetes, though most under the supervision of the physician. Though the doctor will diagnose your diabetes, prescribe your medication, a few doctors send their patients to a diabetes educator for follow-up. And I'm talking about the private sector, where you have the opportunity to have a diabetes educator consult. But very few doctors do send their patients to a diabetes educator for follow-up or on diet and everyday management issues. A diabetes educator generally has more time to spend per patient than a physician or a GP, and can address lifestyle issues in depth. Diabetes can be treated with medication, and more importantly, can be prevented or delayed with lifestyle changes. A professional who is able to facilitate such changes is a diabetes educator. Diabetes educators are medical professionals who work directly with the public and teach diabetes prevention and treatment. Professionals in this field concentrate on helping patients adjust behaviors relating to healthy eating, staying physically active, monitoring their blood glucose levels, taking medication the way it's prescribed, coping with the stress of diabetes, and reducing risks. Individuals with diabetes will be more successful living with diabetes if they have the support of diabetes educators. Diabetes educators are essential in the prevention of diabetes, helping to identify people at risk, and providing education and counseling is a vital role in the 21st century healthcare. And we also help people diagnosed with diabetes to follow lifelong care plans to manage the condition. Diabetes educators are at the forefront of educating and treating people with diabetes. While doctors may help to create a diabetes care plan, it usually falls on the diabetes educator to provide care and to educate patients on managing diabetes. I'd like to quickly say a little bit about Diabetes South Africa.
It's a non-profit organization founded in 1969 to provide healthcare and support for people with diabetes. Diabetes South Africa informs, encourages, and supports all people with diabetes, as well as their families and caregivers. Our work includes promoting public awareness of diabetes, its symptoms, and its risks. Diabetes educators give people with diabetes the tools and ongoing support they need to follow their diabetic care plan in their daily lives. So let's take this opportunity of this World Diabetes theme of access to diabetes care. And you know, there are many organizations like the Lions, the Diabetes South Africa, and also the Diabetes Alliance, which is making great inroads, especially with the public sector. And I think that is where we are needed the most, in the public sector. So let us all join hands and try and get this theme on the road and get our patients with diabetes, you know, better improved services. Thank you very much.
Thank you so very much, Sister Elsie. You know, the enthusiasm about the topic is so clearly evident in your voice and in your expression. So I think you've left us all with a wonderful message. Thank you ever so much. Our line, Carol Brown, is back on. She seems to have sorted her computer issues. So Carol, welcome to you. Can I now hand over to you?
Thank you very much, and sorry for that interruption. The Wi-Fi router had run out of power, and so I just had to connect a power bank onto it. So I had been saying the difference between a nutritionist and a dietitian. I really work at a public health level, more than at an individual level. But diabetes is very much a public health issue in South Africa because so many people have it. There is a role for individual counseling by dietitians, very much. But in terms of looking at what the country as a whole has to do, more guidance comes from people like myself who work at a broader scale. So now I want to ask all of you questions. I wish I could see you. If you had to choose a diet that you were going to follow, a healthy diet, would you prefer your diet to promote a strong immune system, prevent certain types of cancer, prevent and manage type 2 diabetes, prevent and manage cardiovascular disease, promote good eye health, help prevent overweight? And because we lost so much time, I'm not going to get some of your answers, but I'll just give you an anecdote. I gave a talk similar to this a few months ago at the Open Door Crisis Care Center. It was targeted at the managers who look after their safe houses where victims of violence can go for a period, because they need to balance their catering budget together with the needs of the clients. And it included the social workers, because they also are in touch such a lot with these clients. And they were all going for a diet that could promote a strong immune system because of the environment we're in with COVID. But it's actually a trick question, because a healthy diet for South Africans is the same for all of those. It's the same eating plan for all those conditions as for someone who doesn't have any known diseases or known risk of lifestyle diseases. What a healthy diet is described in the South African Guidelines for Healthy Eating, and they're illustrated in the South African Food Guide. They have all the health promoting and disease preventing properties on the previous slide. So a healthy diet will help promote eye health, will help promote the strengthening of the immune system, will help prevent diabetes. But if you do have a weakened immune system, or you do have diabetes, or you do have high blood pressure, the same diet is used to treat them. And this is the South African Food Guide. You see it's got starchy foods in the middle. And I did hear the words about too much carbohydrates, but here we're going to talk about more of that later. They still remain central to most of our diets. Large amounts of vegetables and fruit. Importantly, the legumes, lentils, dry beans, soya mince, split peas, whether they come in the tin version. Plant oil, margarine, and peanut butter. And then a smaller amount of foods from animals. So what we see here is that most of the food in a healthy diet comes from plants. That's the big message I want you to have there. So I'm not going to give you a whole eating plan for an individual because time does just not allow it, but to give you the key points. For any healthy eating plan, any healthy diet, the foods that should be included are just as important as those that should be excluded or should be used in small amounts. So a popular in recent years, but important message is unprocessed or minimally processed foods. Super maize meal, especially one of these ones that are instantized that you don't have to cook it, does not have the same nutritional value as eating corn on the cob or merely cooked on the brine, because a lot of the goodness has been broken down, a lot of the vitamins have been lost, and it's in a form then when it can be absorbed very easily. So an example of an unprocessed or minimally processed starchy food would be the whole grain starchy foods as against the highly refined. Vegetables and fruits, but again, as close as possible to their natural forms, not in juices. Legumes, soya, nuts and seeds. Nuts and seeds, unfortunately, are still very expensive in South Africa, but when the Department of Agriculture gets its act into gear, the price of those will come down, and then that's a nutrient-dense way to get hold of the good fats. We do have to have some fat in our diet, and that's best found from vegetable oil and plant foods with oil, mostly plant foods and water. So that's what most of your shopping trolley should look like. It should be made of those things. Foods that should only be eaten occasionally, that shouldn't be your staples. Food from animals, and mostly this is because of the environmental aspect of it. An animal has much more of a negative impact on the greenhouse gas collection and hence climate change than plant foods do. So as a globe, we've got to eat less animal foods. Particularly, it's the fatty food from animals that should be not included. Foods cooked in a lot of oil. You can take some plant food and cook it in vegetable oil, but if it's cooked in a batter, it will absorb, let's say French fries, it will absorb a lot of the oil. So it suddenly becomes a very high fat food, and the proportion between fat and vegetable is lost. Salt and foods high in salt because of cardiovascular disease. Sugar and foods high in sugar, especially sugary drinks, should be used only sparingly. It's not only the ones that have got the sugar tax now, this also includes vegetable and fruit juices, even if they are supposedly 100% sugar. And foods with low or no nutritional value. I was talking to friends recently and we were joking that these days if you go to from the youngest kids in a creche or in a primary school, these little 1 rand packets of knickknacks are almost a staple food. Everyone's eating them. They give no value whatsoever to the diet overall. So they don't help promote health or they don't help protect against disease. Additional messages for people with type 2 diabetes relate to the quality of nutrients being important and being minimally processed. So this is a new emphasis that I didn't have in my first 30 years of working. And that's probably why some of the problems arose from people who were having high carbohydrate diets, because they had very low quality overall. A carb is a carb, but the form that you put it into your mouth in is also important, because that's the form it hits the digestive system. So instead of moving more and more to the dependence on the food industry to process foods, we should actually be going backwards. A person with diabetes should have regular meals that are regularly spaced and regularly sized. Follow the guidelines given for their medication. This is important sometimes with regards to the quantity of insulin to match the carbs or with regards to the kind of medication they're on. So I can't give a general message for everybody. There is an individual message also that's important. There's no special diabetic foods that are needed. In fact, in South Africa, it's illegal for someone to label their chocolate or their jam diabetic because all foods can be used by diabetes. It's still a matter of quantity and quality and frequency. Eating plan for the family, and this refers to the point very nicely that the diabetes educator made earlier. It's not an expensive eating plan. It's the basic cost of a healthy eating plan. And it shouldn't be that, okay, you've got diabetes, you're going to have this boiled beans and we are going to have Kentucky Fried Chicken. It's definitely wrong. The whole family should now be switching to a healthy eating plan. And it should be a regular way of eating, not a special diet. It shouldn't be seen as anything different. It shouldn't be, oh, well, we're going to her house tonight for supper. It's going to be very nice because it's a diabetic night. And as a closing point, I've kept it short because I know that there've been a lot of talks today. But as a closing point, care for the environment is one of my big concerns. And this is a headline from an article in the journal, The Lancet, which is probably the top medical journal in the world, where they got a group of people who look at environmental sustainability, and they recognize that the food we eat is one of the biggest contributors to negative effects on the environment. So if we're going to protect this planet, there's only one planet, we're going to protect it for our children and our grandchildren. Everyone also has to start looking at the way they're eating and try and make it more and more in line with healthy eating principles as well as environmentally sustainable principles. I thank you very much. Oh, sorry, I thought there's a joke. I can control my diabetes by eating veggies, exercising regularly, and drinking water, but I'm holding out for better options. Well, don't hold your breath when you're doing that because they're not going to come. This is actually the best options that you've been presented now. Thank you.
Thank you so very much, Lan Carol. Thank you for your presentation and thank you for your passion that is so clearly evident. So absolutely, thank you so very much. And I know I need to apologize to all that we're a little bit over time, but I want to now just extend a really heartfelt thank you to all who presented this afternoon. We are hugely grateful for the comprehensive accounts from the various sources. And I think we will now have a brief question and answer session. And if I could please just ask members of the panel to indicate if you would like to respond. Kim, are you still around? Can I ask you to perhaps coordinate that for us?
Yeah, I'm still here. I don't think you need a huge amount from me, though. Basically, as people ask questions and otherwise answer them, at this point, I don't think you necessarily need to see people in detail question-wise.
Yes,
so
of course.
it is just worth noting before you do that, everybody at the moment but yourself, well, myself, obviously, and Carol are on mute. So if you have a question to ask, can I suggest maybe take advantage of the Zoom hand-raising mechanism, which if you bring up on your Zoom recording at the bottom where you see the participants, there should be 3 little dots in the bottom right. One of the options under that menu is raise hand. That way I can see who's got questions and we can then bring them up as they come up. If that makes sense.
Thank you very much. Thanks, Kim. Okay, open to the floor then. Please feel free.
It's sorry, Naroshi, while we wait for people to ask questions, it also is worth noting there have been some chats going back and forth as we during the presentations. No immediate questions that have arisen from it, but just quite a few notes of thanks to the speakers for the various presentations that they've made.
Yes, wonderful. I've noted those, and it's lovely to have DG Patrick Mills on board, and Patrick has thanked everyone for a very informative webinar, and I think the nature of the presentations today has been already superb. So thank you all once again. Are there any questions coming?
Maybe just one point from me, Naroshni. I was just advising Naroshni that basically I'll need a little bit of time to make this recording ready, but not much. So come, I suspect Monday, I should have it up and available, probably on YouTube or something similar. And I will then give you the details and we can distribute so that people can watch this recording.
Oh, that's absolutely wonderful. Thank you so very much, Kim. And I think if there are no questions, it's probably a sign of
sorry, I do see
oh, there is one. There is
one question by chat, yes, from
yes.
Marianne. If I could just read it: a drop in glucose between meals, is that an indication of pre-diabetes in a normal weight individual? Obviously, I have no idea who's best to answer that question, but all I can do is read it.
Well, I'm happy to answer that question.
Thanks, Professor.
It's not a, it's no. I mean, there's two answers to that question. There's one that I don't understand, and I'll mention that later. But generally, pre-diabetes, there's actually a rise in glucose after a meal. So there's two ways that you can diagnose pre-diabetes. You can diagnose that with a fasting glucose. And the one definition is a fasting glucose. We follow the World Health Organization, so it's a fasting glucose between 6.1 and 6.9. The Americans are a bit stricter, and they lower it to 5.6. So in America, between 5.6 and 6.9, you have pre-diabetes, and in South Africa, between 6.1 and 6.9. And then another way of diagnosing prediabetes is with an oral glucose tolerance test, where they give you some glucose to drink and measure your blood glucose 2 hours later. And if it's between a certain value, it's prediabetes. So that means it's gone up. So generally, people with prediabetes, they don't actually deal with the glucose load efficiently enough, and their glucose levels generally go up. The more complicated answer is that in incipient diabetes, and it's something that I still don't understand. People have tried to teach it to me, but I still don't understand it. There can be a drop in glucose. So some people who are on their way to develop diabetes, they can develop postprandial hypoglycemia. That means their blood sugar does drop after they eat. But by and large, the response to your question is that the majority of people with prediabetes, their sugars go up. I just want to add while my camera's on is that I know that you started the webinar with me speaking, but actually in the life of a person living with diabetes, I'm the least important. I think your patient is the most important, and your diabetes educator is absolutely essential. And a very underestimated person of the multidisciplinary team is the psychologist and the psychiatrist. And the WHO best buy in diabetes care is eye care and foot care. So there's no doubt that the podiatrist is also essential in a person living with diabetes. And then there's no doubt that diet is also essential. So out of everyone that's spoken today, I'm actually the most dispensable. And so a diabetic should definitely see an educator, a dietitian, a podiatrist, and a psychologist or psychiatrist more regularly than they actually see the endocrinologist. And that's something that we can all fight for together, because medical schemes have not enabled it like that. And as all the speakers said, in the public sector, you know, just I can talk about the Western Cape, we don't have any podiatrists in the public sector, and it's something we want to fight. We also don't have ready access to dietitians and psychologists. So it's something that on World Diabetes Day, when we're talking about access to care for our patients with diabetes, if not now, when, I think those are things that we can all advocate for together.
Thank you so very much, Professor, for that. And I think you've actually summarized the importance of every one of the speakers for today's webinar, including yourself. So thank you ever so much. I see there aren't any more questions coming through. So may I take this opportunity then to once again thank everyone, presenters and people who've logged in. I think your hearts are all in the right place. And I think this month, let's take up the challenge to create as much awareness around this illness as we can in whatever ways and means are available to us. And as Kim has very, very kindly said, the webinar has been recorded, and it will then be made available to everyone who was unable to then participate in the live version today. So thank you all, and thanks for sacrificing your Saturday afternoon in the main, and I wish you a very, very good rest of your weekend. Thank you so very much. Thanks.